Department of Medicine grand rounds of this academic year. We're delighted to have another season of terrific presentations by outstanding faculty from all over the country. If you would like to see the schedule for grand rounds for this academic year, Margaret from the Department of Medicine will be sharing a link to the schedule in the chat so that you can all access it. But this morning, it's my great pleasure to introduce our speaker, Dr. Tracey Henry. Dr. Henry received her Doctor of Medicine degree from Georgetown University and then pursued a Master of Public Health degree in Health Systems and Policy at the Johns Hopkins University. She completed her internal medicine residency at the Oshner Clinic Foundation, followed by a health policy fellowship at Georgetown University. She then pursued a Capello Health Advocacy Fellowship through the National Physicians Alliance in Washington, D.C., and in 2017, she was the Presidential Leadership Scholar. Dr. Henry is an assistant professor of medicine at Emory University, where she is a clinician educator and an attending physician in both the inpatient and outpatient medicine settings. She also serves as the director of the health policy curriculum for the internal medicine residency program's primary care track and is the co-director of the health equity, advocacy, and policy track for all Emory graduate medical education programs. Dr. Henry is the program director for the Emory Impact Mentorship Program, whose mission is to engage, mentor, prepare, advocate for, cultivate, and teach underrepresented in medicine medical students in a supportive, inclusive learning environment through faculty and peer mentorship, along with educational programming to maximize both their professional and personal growth. Dr. Henry conducts research on health disparities, health policy, and the intersection of mental health and primary care on chronic diseases. She is the recipient of numerous awards, including most recently in 2021, the American Medical Women's Association Exceptional Mentor Award. We're so fortunate to have her here with us this morning. She will be speaking to us today on addressing the social determinants of health from bedside to policy. Thank you so much, Dr. Henry.
Thank you, Dr. Jassel, for that very warm welcome and for having me here this morning. Just very briefly, a little bit about myself. I'm from, was born in Jackson, Mississippi, from the South, and did a lot of my training there, and then later moved up to many of the places that you mentioned in your welcome. But I'm often asked, how did I get involved into healthcare policy and advocacy and addressing, the social determinants of health, and how that became my passion and my interest. And I always tell learners, and I tell my friends and colleagues, a lot of this developed out of really a necessity. Is just growing up and being a witness, firsthand to a lot of the health inequities that we see in healthcare. Some, pivotal events in my life have been my sister actually dying while waiting for a kidney transplant while a medical student. Also, the same time in medical school, I had my cousin who was a college student was actually died at the hand of gun violence where she went to school. And even also, again, at that same time, I my uncle, one of my favorite uncles, one of my interests in mental health and their intersection in chronic diseases and how we manage it in primary care really stemmed from the sort of the downstream effects that he had and not having access to appropriate mental health. And then also died again also while I was in medical school. So a lot of those things were pivotal moments and events for me, and what has led me to my interest in advocacy, my interest in policy, my interest in addressing the social determinants. And so with that said, I would definitely, I'm happy to be here. And so let's begin. In terms of disclosures, I have none. And our objectives this morning are to be able to define the social determinants of health, describe barriers to addressing the social determinants, And I would like to go through and review some of the things we're doing back at my home institution. And then at the end, discuss policy recommendations for addressing the social determinants. So a little bit about my practice. I practice at Grady Memorial Hospital. It's the largest public hospital in the state of Georgia. And I do a lot of my primary care at the Grady Primary Care Center, where I'm the assistant health director, and we're also the largest primary care center in the state. We're staffed by both Emory and Morehouse residents and general internal medicine and subspecialty faculty. Georgia is ranked 39th in the United States for overall health and 47th in the nation for percent of population uninsured. We primarily serve as African-American, Hispanic, Latinx, immigrant populations who are resource poor and low socioeconomic background. And this is the data actually pre-COVID, but we had about 50,000 outpatient visits a year, and our payer mix were about 30% Medicaid. About a quarter of our patients at that time were uninsured, but a lot of that data has changed post-COVID. And so, like many Grand Rounds presentations, I would like to begin with a case presentation. So this is no different. And so we start here, and I always like to give my patient a name. So we're going to call her Mrs. Jones. And she's a 50-year-old female. She has a history of hypertension, type 2 diabetes, and HFrEF. She was admitted twice in the past month with a heart failure exacerbation and once for hypoglycemia. She's a widower and mother of 3 and takes care of her aging parent. She works 2 part-time jobs. She returns to the clinic for a hospital discharge follow-up. And so, to the resident or learners and, and folks in training, what are the issues? Is it ischemia? Is this AFib or RVR? You're trying to figure out, why does she keep coming back, right? And why is she having so many readmissions? Is it hypothyroidism? What are some of the other medical causes? And the reason why we may think this way, because this is initially how we are trained to think. But what else could be going on? And that's what I challenge you today as we go through this presentation. Could food insecurity be playing a role? Perhaps the patient, she is adherent to the therapy that you've given her, and you told her to take, her mealtime insulin, you told her to take her long-acting insulin, and she's doing all of those things that you told her, or perhaps because of low literacy, she didn't realize that only take the mealtime insulin when I have a meal. And she's actually, because of food insecurity, she makes sure that her kids are eating first, her aging parent are eating, and so she's not eating as much, and she's getting hypoglycemic. And so, how often do we think about all of these other things that could be going on in our patients when they come into the exam room? Perhaps it could be cost of treatment. There's no copay for her to sometimes follow up for outpatient appointments or medications. Transportation could be an issue. And so we have to think about all of these different things that could be going on outside of all of the other medical factors. And so, getting to the root problem, American social determinants of health. And this is from our former secretary, Alex Azar, and he said this in 2018. He said, for many, social determinants of health is an abstract term, but for millions of Americans, it's a very tangible, frightening challenge. How can someone manage their diabetes if they're constantly worrying about how they're going to afford their meals each week? And how can a mother with a son who is asthmatic really improve his health if it's their living environment that's driving this patient's condition? And this can feel frustrating, and this can feel frustrating for many of us who are taking care of patients in these predicaments, because it's almost a fruitless position for a healthcare provider who understands what is driving the health conditions they're trying to treat, who want to help, but can't simply write a prescription for healthy meals, a new home, or clean air. And so before we get into more of the presentation, I always like to make sure that we're on the same page, and that we know key definitions and terms. And so what are the social determinants of health? And this is taken from Healthy People 2030. It's the conditions in which, in the environments where people are born, live, learn, work, play, et cetera. and age that affect a wide range of health functioning and quality of life outcomes and risk. And then to put it simply, it's all those non-medical factors that affect our patient's health. And that's, the sort of the easy and quick and dirty of how to say that, just the non-medical factors that affect our patient's health. And that can include education, that can include healthcare access and quality, neighborhood and then built environment, economic stability, social and community context. But I would argue that it's one particular social determinant of health that is actually not a part of this list here in Healthy People 2030, and that is racism as a social determinant. And so you may ask me, Dr. Henrino, what do you mean by racism as a social determinant of health? And basically, it's really important to realize, and this was adapted from Dr. Gee in 2007, that the individual experiences of racism are only the tip of the iceberg. So what we see every day, things we've seen in the news, hate crimes, microaggressions that we may feel, the everyday slights, really sit at the tip of the iceberg. And it's a broader foundation of systemic racism that is far more difficult to observe. And those are the things we see at the bottom, like the media portrayals, mass incarceration, political representation, the redlining practices. And those are really what shape a lot of the policies and the well-being of racial and ethnic minorities. And then so you may also be saying, well, Dr. Henry, I don't understand, how does racism make, a person sick? Well, it can hinder one's educational attainment. It can impede the ability to seek gainful employment, followed by a decrease in potential wages. Then that can also lead to a decrease in access to healthcare, which all leads to potential health outcomes. And that's one particular way that racism can make people sick. Other ways that racism makes people sick could be allostatic load, or that wear and tear on our bodies. And so that's that stress load where we see increase in biomarkers of stress, such as cortisol and CRP, and this has been actually well studied. And then it also can trigger maladaptive coping mechanisms. And so you may see a increase in alcohol and tobacco and other drug use, or even you may witness in some of your patients avoidance behavior. So perhaps they're foregoing medications, or they're seeking alternative therapies to avoid the encountering bias when they come into the healthcare setting, because they feel like they're going to be judged. They feel like that the physician or the healthcare provider is not going to really understand where they are. And so they avoid and have this sort of bias where they do not come into the healthcare setting. And so these are some examples of systems affected by racism. So it's healthcare, it's housing, it's criminal justice, it's education, it's the economic stability or the or wealth gap. And these should sound familiar to you, because these are those same social determinants of health that I listed previously on the screen with Healthy People 2020. This is taken from the Kaiser Foundation. But our social determinants affect our health outcomes, our mortality, morbidity, life expectancy, healthcare expenditures. And then so the impact of social determinants of health is quite significant. It's been well said multiple times that what we do, and we might like to think of ourselves as the best clinician and know every evidence-based principle, and and you're just awesome. But a lot of what we do, it's been cited that 20% of what our patients that affect our patients' health, it's very little is attributed to clinical care. And there is some sort of controversy, and some studies are going on now that say, how can you really sum this up to say that 20 is clinical, 80% rest is affecting the non-medical factors that affect the social determinants of health. But whether you believe in that criticism or not, or maybe some of the studies whether they're flawed or not, what we do know and what is clear is that what happens outside of the exam room affects our patients and their health more than the healthcare that we provide in the exam room. So I'd like to draw attention to this particular study by McKinsey in 2019. It was about 2,000 participants in the study. And what we saw here is that 53% of those surveyed were adversely affected by at least one social determinants of health, meaning they had one unmet social need. And it's listed here, at least a third of them listed food environment, followed by community safety and housing, or some of the areas where they had unmet social needs. And another thing that's notable from this particular survey and study by McKinsey is that patients, if they had food insecurity, were 2 times more likely to go to the emergency room, or if they had transportation needs, they were 2.5 times more likely to go to the ED. And if, community safety needs was actually 3 times more likely to go to the ED. So, having these unmet social needs definitely pays a cost to the patient and also to society. And going a little bit further, when we speak of cost to society and how much we spend on healthcare, if you look at the top, the black line is the United States, and we spend close to 17-18% of our GDP on healthcare, which is far above the rest of the developed nations. And so you may be saying, if we spend so much on healthcare, what are our health outcomes like? We're looking at the top, developed nations here on this slide, and this is a study by the Commonwealth Fund. We look at the United States, and our overall ranking of 11 out of the top 11 is actually 11 in terms of overall ranking on healthcare performance and outcomes. We're not so bad in care process, but in terms of access, equity, and health outcomes, we do rank last. And so what we have noticed over the years, and this is actually improved since the last time I've looked at this, is sort of countries that invest in social care actually have better health outcomes. And so we look at the United States, and so previously, the United States, we spent a lot less on social care, so things had changed within the last 10 years, but previously that ratio was a lot lower. But the other countries listed here have way better health outcomes and also lower healthcare costs, but they also invest more into social care. So they're investing more upstream into social determinants of health in their countries. And so getting to the term upstream, so you hear a lot of that, what does that mean, moving upstream? And they're kind of, these buzzwords when you discuss the social determinants. But this is nice. This is from Health Affairs blog. And so I like this infographic. And so downstream are those things, those medical interventions, those things we're doing at the point of care, particular social needs that we're taking care of our patients. And what we want to do is sort of move upstream. We want to have community impacts that we see at the top of the stream there. And the ways to get there be changing laws and policies and regulations. And so another example of upstream versus downstream is that if you take the social determinant income, downstream would be ensuring that chronic disease prevention programs are accessible to patients who have low income. The midstream thing, maybe connecting patients with social work, community programs, back to work programs, job placement programs. And then the more upstream thing would be advocating for living wages. And so those are a really great example of how we could do things in a clinical visit individually ourselves downstream, addressing the actual social need, versus what we ultimately want to do is get to upstream where we're making policies and widespread changes for sustainability. And so, right now you may be wondering, so why the hype now? Social determinants, I remember learning about this, 15, 20 years ago. And so why such the emphasis on it now? And really it's because we have a new paradigm in healthcare where value-based care is more about clinical excellence and where we must address these social drivers. And so we have a move now towards reimbursing health professionals for value instead of volume, and for outcomes instead of process measures, and for using benchmarks like total cost of care. For example, if you think about a person who has an MI, previously, when we cared more about volume and sort of just processes, we cared whether or not the patient had an aspirin on arrival. But if we think about value-based care, what we really care about is the patient's 30-day mortality. And so that's what we want to look towards more, and that's what we're moving towards. In order to get there, you have to start addressing sort of these social determinants of health. And so we also have realized that we have to put more emphasis on reduction of social risk, such as food and housing security. And we do know that those are closely linked to poor health. And we also have learned that clinically complex patients also have socially complex issues as well. And so, we get back to our case. And this is our case, Ms. Jones, who came in multiple follow-up after multiple readmissions. She's coming in with hypoglycemia. And so, after discussing what we've had in the past several slides, as her physician, what are you thinking now? What do you think could be the cause of her multiple readmissions? And I would say, as her physicians, we bore witness basically to the impact of upstream social determinants of health on her clinical presentation. There are generations of unjust policies that had these downstream effects. So, 30 years ago, she was unable to buy a home in a desirable neighborhood as a result of redlining policies. Her current community suffered from decades of disinvestment. She had financial challenges that resulted from scarcity of well-paying jobs in her area and in her neighborhood. And really, all of those different things contributed to her increased risk of poor health outcomes and why she presented with multiple times to the emergency department. So let's switch to barriers to addressing the social determinants. I think we all know it's important, but why aren't we all addressing it? Or why are we doing a better job of helping our patients and populations? And so some of the barriers to social determinants, a lot of it could just be a lack of awareness and knowledge, lack of financial resources, maybe time and competing demands in the clinical visit. So you're trying to get the patient's hypertension and diabetes, the heart failure under control, and perhaps not have enough time to even screen the patient for their social determinants or connect them to the resources that they need. Other barriers have been confusing terminology. Is it social determinants of health? Is it social influence? Is it social needs? What does all that mean? The health professional perception of what a patient needs, and also medicalizing the term social determinants of health. And finally, would this be more clicks for me in the visit? And I think that leads also, you hear a lot of physicians and other healthcare providers mention the more clicks and leading to burnout, more work and kind of stuffed into the very short, brief 15, 20-minute clinic visit. So this was a study from JAMA in 2019 that looked at the prevalence of screening for food insecurity and housing instability. And they surveyed over 2,000 physicians in their practices, and they found that about 1 in 4 hospitals and 1 in 6 physician practices screen their patients for the social determinants. And again, in terms of barriers, in this study, the biggest barrier were lack of financial resources, followed by lack of time. And so lack of knowledge wasn't as a barrier for the physicians in this population. And I like to think, because we're an altruistic profession, I'm happy to hear that lack of incentives was not a barrier as well. Like, people wanted to do the right thing, they wanted to address it, but it's more so the lack of financial resources and time in the visit that prevented many from addressing the social determinants. So, are they social determinants or influencers? This is from Dr. Simon at Kaiser Permanente. And so he wrote in 2017, the word determinants doesn't allow for resilience, hope, or effective interventions. Some people defy the odds, and they are sometimes things that healthcare can do to improve the odds. So do we need more research in the name of social determinants of health? And he says, no, bad environments don't always produce bad health. Social factors influence the probability of bad health outcomes rather than determine them. So let's swap determinants for influencers. Nothing is your destiny. So basically he's arguing that saying determinants sound very fatal, very much so lacks hope for the patient. And so perhaps we should have never used the term determiners, but maybe social influencers. And then another thing you may hear, social determinants of health versus social risks versus social needs. So again, if we, hone in social risk factors, basically those are just the specific adverse social conditions such as food insecurity and housing instability that are associated with poor health. And then social needs are really those downstream, the fact that the person needs food or has a housing need. Those are the things that we're actually addressing. Those are the things that you're addressing in your clinic visits. So those are actual social needs that we're doing. And the reason why I'm being so particular about sort of, definitions and being precise, and maybe in the end, it doesn't matter as long as we get the work done. But, sometimes you'll hear some interventions, you'll hear industry folks and different organizations say, well, I addressed all the social determinants of health, but really what we're doing is we're providing resources to address social needs at the point of care, in our clinic visits. But what we really want to do when we say social determinants is something upstream. It's changing policies so that we can have widespread sustainable change. And so another barrier is medicalizing the term social determinants of health. And what that means is sort of that personal behavioral social issues are viewed through a biomedical lens. And the reason why we are worried about that is because this could lead to more healthcare versus more cost-effective community-based interventions. And so an example might be, say, a housing benefit or rent benefit for, and some Medicaid programs do this, offer a housing benefit for their patients to pay for the rent. But what happens to that patient, say, if they switch in states or, insurances, things happen and they move, or they switch insurances, do they no longer have the housing benefit? So are they now homeless because the Medicaid program or the insurance program paid the rent? And so we want to get away from doing that. What we, again, want to do is have more upstream approaches to addressing the social determinants of health and not per se just adding these on as a benefit package. And so, moving from bedside, student and resident-led initiatives. And so I really would like to highlight the work that my students have been doing over the last couple years, and also some of our resident-led initiatives. And this is one particular study that actually started with a lot of our medical students, but also our medical students stayed on and became a resident at our institution. And so that she conducted this particular study, and it was to explore whether social determinants of health are being assessed or screened for by our primary care clinic at our hospital for our internal medicine residency program. And then she also identified barriers, and then she compared the patients' reported adverse events and what they thought their social determinants of what they said their social determinants of health were versus what the residents thought they were. And so this is the resident here, Dr. Treadway. I would like to just give her a shout out and highlight there, but she's definitely started off as a student and kind of continued her work on, and she's actually just started her PGY3 year here. And so the method, the way they conducted the study was that we gave printed surveys to our patients in the lobby while they waited, and this was pre-COVID. And we gave the residents a very brief 8 self-report multiple choice question that was online that they could do very quickly. And then basically we just asked them to, say, what do you think the main social determinants health are for your patients? And for the patients to say, what are the things that you are struggling with or dealing with and the main issues where you need help? And so this is the result. We had about a 30% response rate for the patients. So about 1,000 patients filled out the survey in the waiting room. And we had 10 SDOH categories that are identified. And, at least, 25% of the patients said I had at least one unmet social need. And so what we found, looking at the top left graph with the orange bars, is that 77.8% of the residents reported that they screened less than half of their patients for social determinants of health during the clinic visits. And that if you look at the bottom right with the blue bars, the barriers are the same that we saw earlier, competing demands, lack of time, even not sure how to screen effectively. And so greater than 70% of the residents said, hey, we need more help, we need more resources, we need additional social workers and patient navigators and more time in the encounter to get this done. And then so very interestingly, this is the list of what the residents thought their patients lacked. So 60% thought they lacked transportation, and that's why they're having some issues sometimes getting to their appointments, followed by unaffordable healthcare and housing instability. But when we compare what the residents thought their patients' problems were versus what the patients said their problems were, so you look here on the right side, the number one issue that was cited by our patients was food insecurity, followed by unaffordable healthcare, which is what the residents ranked as number 2, and then followed by unemployment. So as you can see, there's not a whole lot of congruence from what the residents thought the problems were versus what the patients said their actual problems were. And there was a fourth patient concern, not even ranked by the residents, and that was social isolation. So in conclusion, the residents, the information about social determinants of health, and they knew that this was a valuable thing to do. This is something we needed to do, but really just needed more resources in order to start screening more effectively and more consistently. And another initiative, and I will say because of the result of this particular study, we've moved forward and we've actually gotten more social workers in our primary care clinic. We have more resources, we have more standardized things that the residents can use so that we can screen more effectively, more consistently, and regularly. And so this was another initiative. This was student run, our medical students, and this was the Grady Healthy Living Program. And, we targeted our area where Grady is located. There's a lot of different health disparities in employment, education, and poverty. This is the leadership team and where they were in their training at the time of this particular project. And so the purpose of it, was twofold. Obviously, education for the patient and helping improve their chronic disease management, but also student education as well from M1 to M4. So we introduced the first-year students to social determinants of health. We improved their ability to assess patient management of chronic disease starting very early on in their first year. And students had an opportunity to practice and improve upon their motivational interviewing and health coaching. And then it was an opportunity for our fourth-year medical students to have a medical education opportunity and mentorship to mentor the first-year medical students in health coaching and motivational interviewing. And then, of course, all of this was done with faculty oversight. And so, with this program, they also developed a screening tool so that we can screen patients for the social determinants of health in the clinic visit, and they adapted this from Health Leads. This is a screenshot of the original tool that we used. And we also developed in 2018 this community resource guide using a lot of some of the resources on Bertha and 211. And so, we did a data analysis, and at the end, in our inaugural program, we had 28 student health coaches, and they overall all reported an increase in their self-reported ability to define social determinants. They knew how to access and find resources. And then also they had confidence in health coaching ability. And so it was really a success of how we were able to have the students work with each other, have the students work and learn from patients, and get patients the right resources and care that they needed in a timely fashion. And so, another thing that we could do at the bedside, individually is leveraging our EMRs. So many of us now have EMRs where we can actually do a lot of the screening for our social determinants. And so we have Epic EMR at our institution, and we have what we call the social determinants of health wheel. And so we actually have our nurses who triage the clinic visits. They actually been trained on how to ask these questions with cultural humility and sensitivity. and inputs the data into the screening tool. And so that sort of minimized some of the issues that the residents previously said, time and competing demands, not having time to screen. And so now that we have a physical tool in the EMR, that has mitigated a lot of those barriers. And then we link them to community resources. And if they have at least 3 challenges, it automatically generates a social work referral so that social work can help the patient navigate these resources. And so I'll show, places again that you can. So you might say, our EMR doesn't have this wheel yet, or tool, or way to connect automatically and generate the resources. But you can also, if you do have time, you can actually go to sites like this and actually look this up. In San Diego, there are about 2,726 programs here related to social determinants of health. And for instance, if I had a patient that had some issue with housing, I'll click on housing. And then there were about 80 programs that came up with housing instability. And with the recent overturned by the Supreme Court of the eviction moratorium, you may have more patients saying, I'm having some issues paying my rent and may need assistance. And so literally you can click here and get to a lot of these programs. Similarly, 211, you could do the same thing. This is the 211 for San Diego. All right, so what can we do during policy? So we talked about social determinants, the barriers, all the different definitions, and what you could do individually at the bedside. But again, I kept saying, we need to move upstream, because moving upstream is what we need for policy changes, for systemic changes that can help our patients at the point of care downstream. And so that's really the importance of policy initiatives, right? So if I help a patient in my visit today and I feel great, like they needed food and I got them food, I got them, food pantry, I have someone come into their house, or if I had a patient with mold in their apartment, I was able to write that letter for them that day that, that encouraged the landlord to, please clean that mold, or this is, harming this patient's health. I helped that one patient, right? But I didn't do anything about the mold that could be in the apartment of the patient next door. I didn't help all the other people who may be hungry in the community in that area. And so that's really, again, the importance of why we need to, advocate even as physicians and health professionals for upstream interventions. This was one of the Health and Human Services Disparities Action Plan that sort of aligned a lot of these goals and to move towards addressing social determinants. And this was in 2010. We have something called accountable health communities. And, a lot of this slide and the next slide, these are a lot of governmental interventions where before we invest, the government says, I invest in sort of these upstream, these policy, I need to know that we can do things effectively. And so these are just examples of places where the government has given money to clinics, different states to figure out, what are the best ways? How do I bridge community and clinical services? It's, not have a one-way referral, like, oh, here I go, I'm referring everyone out. But how do I have bi-directional referrals? How can I have the job placement center or a place where a patient might be getting their GED can refer back into healthcare? It shouldn't just be a one-way street. And then the World Health Organization, they have been supporting this for the last 10 or 15 years, and this is health in all policies. And, this is what we really want, right? It's just not for the healthcare sector to solve alone. So we need transportation, housing, nutrition, et cetera, on board. And the way that works very briefly is, say, for instance, we have air pollution, which is the cause of death, and 1 in 8 cause of death worldwide. But, how can we make a difference? So if you start at the top left, you have, say, if this is in the US, Department of Energy, right? We want sustainable, clean fuels. And so less wood, and diesel, and coal. So we need to work with them, right? Housing, better ventilation and cooking. We have industry and waste management. We have transportation. So we need more low emission vehicles and other car alternatives, walking paths, bike paths. And so that requires planning on all ends. And we have urban planning, so we say housing and urban and development, compact and efficient housings could be built. And then we move on to other local and regional authorities, planning codes. And then finally, at the end, in the last row, we have the health ministry or healthcare sector coming into play. And so the healthcare sector is what drives all the conversations within all of these different areas. And so that's what we mean by health in all policies. We need everyone on board. It's a fallacy to think that we can solve this alone as healthcare professionals. The CDC also has their own, if you go into their website, they have tons of different policies that they recommend and that we could do from a state base and national. And this is what one of their initiatives is called Health Impact in 5 Years. And they use this pyramid model because basically what they're saying is they would like to target their interventions to those things that do not require a lot of individual effort and has the potential to impact the largest amount of people. And so at this bottom in the red box, early childhood education. So targeting that, should affect everyone. Clean diesel, buses, public transportation system, all of these things can affect a large amount of people. And so they want to start, there, and that's sort of their basis for how they are addressing or suggesting we address social determinants from a policy standpoint. Other things we can do are Medicaid initiatives. I listed here, obviously California has had several, been a part of lots of different accountable care and improvement in healthcare through different demonstration and process and performance metrics to address their social needs. And based on at least the data, not living in California, it looks to be that it's been successful. And then another state of innovation models, as you see, California highlighted here in green, but it's definitely one of the states that get money, has been receiving money to improve care. How do we deliver care, connecting communities and clinical services together. Another way that you can do, and this is a policy intervention, but also you could think about it, you could be doing this individually as well, related to policy, and it's coding for social determinants of health. And so in 2016, this became effective. We had about 10 categories of Z codes, and it can be documented by any clinician. So anyone on your healthcare team, your nurses, nutritionists, physical therapists, and it was highly underutilized. And so CMS posted this in January 2020. They did a study. In its first year, it was hardly used at all. And so there isn't reimbursement for these Z codes. These are non-reimbursable codes. But what this does is help us figure out what are all the different problems, the issues, the social needs, and where, so that we can have resources targeted to certain populations and areas. And so, if we were using these Z codes, that will show us, that there is a bigger problem, even though we know there's a problem anecdotally, but having sort of the numbers there does help, where this could potentially be a way for actually billing for certain social determinants of health that are reimbursable in the future. And these are some examples. For instance, I'm sure you've had patients that had low health literacy that you could, these are all the different types of Z codes and sub Z codes. You may have patients with housing or economic insecurity. And so you would simply put those in at the end of your encounter. And other policies that you can advocate for. So this actually was passed in 2018. It was $100 million to fund more research on how to pay and address and implement social determinants of health services. And these are two pending legislation. This was sponsored by Representative Nanette Diaz-Bergen in California. It has about 40 co-sponsors on it, and they're asking for $50 million. But the Biden administration actually, with one of his other proposed pieces of work and executive orders, will actually like to give more than the $50 million. But it's called the Improving Social Determinants of Health Act of 2021. So when you do your federal or going to the Capitol and your Hill visits, you can think about HR 379 to advocate for. And then another one, this was introduced actually a couple of years ago and reintroduced during this congressional year, and it's House Bill 2503 and Senate Bill 296, but it's the Social Determinants of Health Accelerator Act. And this one, has bipartisan support. It's only for 25 million, but they also have about 40 co-sponsors on the bill as well. And, again, both Republicans and Democrats support it. So perhaps, this will get approved pretty soon. And the great thing about this particular act is that it will develop an interagency council. So remember, I said that it should be health in all policies. We should have everyone on board: education, housing, energy, labor. And so this particular act will have a council like that so that we can figure out how we all work together to address the social determinants. And then other keys to advancing would be, health equity and payment policy. And so, I do want to just mention, what can you do from an educational standpoint? A lot of the major organizations definitely support training SDOH in our medical schools and residency programs. Very interestingly, there was this ACE consortium changing the Consortium for Changing Med Ed through the American Medical Association. So they interviewed about 28 of the participating schools, and was happy to see that at least 60% of the schools said that social determinants of health training was a priority. And so we are moving in the right direction. And again, they were also asked, is this offered in more than one course or module or clerkship? And so about half of the schools said at least talked about it in a course, a module, or a clerkship. And about a quarter of the schools actually have a theme, so a thread that it is tied to the school's mission, and that's what we have at our institution. And then our medical associations, our professional homes have also been involved in dressing and making sort of tons of different recommendations of things that we can actually do, like the American College of Physicians. And I was happy to serve and work on the committee in 2018 that developed this paper on addressing the social determinants of health. And, they called for a lot of changes in UME education, GME education, making sure we had adequate and efficient funding for federal, state, and tribal and local agencies to address social determinants of health. And how can we develop best practices for implementing, how do we address it in our EHRs, right? So that we can minimize our clicks and leverage technology so that we can help our patients and populations. And then also the Social Determinants of Health Society of General Internal Medicine also came out with a position paper in 2020. And I do like that in this particular paper, they mentioned something called a health impact score or health assessment score. And it's very similar to how the federal government scores federal policy for fiscal impact. So they suggested that we do the same thing. So perhaps there's an organization or interagency council that reviews all federal policies before they're passed, put a score on it. How is it going to address health disparities or health equity? Or, is it going to further, worsen health disparities? And so put a score on it, actually think about and be intentional about all of our federal policies and how is it helping address our social determinants. And then the National Academy of Medicine also came out with a report, and basically, all these organizations are, saying the same thing. We have to integrate social care into healthcare, build a workforce, have a digital infrastructure. And they came up with the 5 A's. And so I like the way, in a particular example, be with transportation. So if you had a patient that that needed transportation, the first thing you want to do is awareness. So you may ask the patient about, what is your access? How are you getting to your clinic appointments? And so adjustment might be something you need to do. So reduce the need for in-person appointments. And we've learned that during COVID-19 that we don't have to bring a patient back always in person. We could utilize telehealth services. And so, that might be a better way of helping that patient so they wouldn't have to take off work and find childcare. Or you could assist that patient maybe with ride sharing or alignment, invest in community ride sharing. Perhaps multiple people are coming from different communities and places, they can all share in the community ride sharing. And then advocacy, again, working upstream to support health policies. And so in closing, in moving from bedside to policy, in addressing social determinants. So in a nutshell, we have to bridge health and social services. We need to move from a system of being reactive to being proactive. We from a system that values acute care to preventative care. And again, this bi-directional care and referral system, instead of just us always referring out to the community should be referred back to us. And then we can build on things that we already are doing. We need a national strategy. We need multi-sector collaboration. We need interagency council. We need everyone on board. We need, the health and all policies sort of approach. And it's not for us to start to solve. And we can build partnerships with our communities. We can't do this without talking with communities. We have to, listen to our communities. What do they need? What do they want? And we should also be leveraging that data as well. And so in recapping, we were able to define the social determinants, all those non-medical factors that affect our health. We list many barriers from lack of time, competing demands, medicalization of social determinants of health, confusing terminologies. We review the initiatives that we're doing at my institution, and there's tons of policies and work are out there and things that we can advocate for on a national level. And of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. And special thanks to these students and other folks on our team. This is my contact information. Healthcare is not so easy. I thank everyone and for having me here today. Here's the QR code for those who need CME credit.
Dr. Henry, thank you for that inspiring presentation. I think that all of us who are healthcare providers on the front lines, I think we all experience the sense that although we care for our patients and address their medical problems often, it feels like putting a Band-Aid on a large gaping wound that's actually their social determinants of health. And I think your presentation has really inspired us to recognize that we can do more to address that gaping wound. We have several questions from Dr. Tanaka. Thank you for all your wonderful patient care and research. Does your health coaching program include implicit bias training for medical students? If yes, when in medical training do students receive this training?
That's a very good question. Actually, this the health coaching program did not include at that time implicit bias training, but I am also one of the new thread directors for diversity, equity, inclusion, racial advocacy at Emory, and we are including implicit bias training in the medical education. And ideally, since there's so many people who have to be trained in the beginning, we were doing it in phases, but you do it in the beginning, sort of orientation or the first month or so into medical school. Once you're at the point where everyone has been trained and you're bringing on new students.
Excellent. And from nurse practitioner Sats, is there any ongoing communication of the results of your patient's status of social determinants between the work at Grady and local and state governments with the purpose of remediating these unmet needs?
That's also a really good question. I mentioned this last night at our discussion town hall. Our medical student team actually had a resolution on racism as a public health crisis that was declared in our county. And as a result of that, their advocacy and getting that declared, we're actually currently working on policies that we can suggest and things that we can actually implement to address a lot of sort of the effects of systemic racism and social determinants of health within our county. And so that's one way. And then of course, our state does track a lot of that data, and we are, keeping track of, where we're seeing a lot of the issues and where we're seeing the high utilizers and patients that are most affected in need. And that's where we target a lot of our resources.
Excellent, thank you. From Dr. Jiang, one of our chief residents, thank you for this illuminating talk. As resident physicians, what are some ways we can be involved and affect upstream change? What opportunities are available to us?
Well, my favorite always is to have learners, trainees join organized medicine groups. I am a proud member of American College of Physicians, Society of General Internal Medicine, and they have very sizable, large advocacy arms. And so, you know, when you have your Hill Day, and we're even still doing Hill Days virtually. I did that with the American College of Physicians this past year. It was actually even almost more effective than going to the U.S. Capitol itself, because we actually had the team there on Zoom, and just a handful of us and cameras on, and we're having longer, even meaningful conversations than we probably would have sometimes in person. And so that's one way to get involved, is because it's really hard. You're a busy clinician, you're a busy medical student, you're a busy resident. So really joining those organizations who can already sort of put some of the language together, can tell you what the policies are, and you develop, you go and you tell your story, the things that you're saying, and that's a quick and easy way to get involved and also be impactful as well.
Thank you, Dr. Henry. I was particularly impressed with the interface that you were able to create with Epic. We also use Epic here at UCSD, and I thought that it was so helpful to be able to have the social determinants of health integrated into the EHR, and for it to link to specific consults or resources. I know that Epic is individualized from institution to institution. Do you know, is this an add-in that can be included for all Epic users? Is that something that we could ask our information services folks to add to our Epic package?
Yeah, definitely. I believe you can definitely ask for that. That is something we have been working on for a very long time, and getting the wheel where it's easy, and having, where do we put it, and, to minimize clicks. So yes, definitely something that you can work with your IT department and with Epic about implementing.
Excellent. If there are no further questions, I want to thank you again, Dr. Henry, for sharing this important and really transformational work with us. We're so grateful to you for all of your efforts. Thank you again for speaking to our department this morning. And we look forward to having you here in San Diego in person in the future. For our Grand Rounds participants, just a reminder, for the faculty and for the residents, you can scan this QR code to complete an evaluation. That's important for maintaining accreditation of Grand Rounds and for improving our Grand Rounds presentations for the future. And for everyone, if you would like to see the speakers that we have scheduled for this academic year, you can click on this link. I hope you all have a terrific day. Dr. Henry, thank you again.
Thank you for having me. Have a good day.